All right, looks like people entering has slowed down a little bit, so we might just get started. So thank you very much for joining the first ever INHSU Early Mid-Career Researcher webinar. It's an absolute delight to be co-hosting this with my colleague Anna Conway. So before we begin, I'd just like to acknowledge Indigenous and First Nations people globally who continue to be disproportionately affected by the war on drugs and the war on people who use drugs. I'm in Australia. I live and work on the lands of the Boonwurrung people of the Kulin Nations. I'd like to pay my respects to elders past, present and emerging. So the way today is going to work, we have two great guest speakers, Matt and Tommy, who I'll introduce more in a moment. Basically, Matt and Tommy are going to give us a presentation on some of the work they've done together. Then we're going to have a bit of a conversation about how they work together. And then Anna is going to facilitate a question and answer session. If you have questions, feel free to pop them in the chat, or you can come off mute at the end as well to ask those questions live if you would like. So as I said, our guest speakers today are Tommy and Matt. So Tommy is a general internal medicine and addiction fellow at Dalhousie Medical School in Nova Scotia, Halifax, Nova Scotia. And he is currently undertaking a PhD by University College London with the Centre for Inclusion Health, focused on understanding and providing medical care for injecting related infections among people who inject drugs. Matt is also based in Halifax, Nova Scotia, where he is the program manager with the Canadian Association of People Who Use Drugs. He is currently an INHSU board member and a knowledge translator for the Dr. Peters Centre in Vancouver. Apart from being an author on academic publications, his freelance writing has also appeared in numerous non-academic publications. He is a current drug user and a formerly incarcerated person. So thank you so much for joining us today, Tommy and Matt. Without further ado, I'll hand it over to you to begin your presentation.
Thanks for inviting us. This is great. And a lot of familiar names, familiar friendly names on the Zoom call, even though there's most of you I haven't met in person yet. So I'll start. I also want to acknowledge Indigenous land. We, Matt and I both live and work in Mi'kmaq, which is the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which the Mi'kmaq and Wolastoqey people first signed with the British Crown in 1725. The treaties did not deal with the surrender of lands and resources, but in fact recognized Mi'kmaq and Wolastoqey title and established the rules for what was to be an ongoing relationship between nations. And this coming Friday, September 30th, in Canada is our National Day for Truth and Reconciliation, recognizing the damages of colonialism and the legacy of the Indian residential school system.
And just some more geographical content on where we're at. We're on the east coast of Canada. You know, you may be more familiar with larger cities like New York and Boston, but we're just as far east, a little bit further east in Halifax, Nova Scotia. And if you're familiar with typical drug supply routes, we have a very pure connection for cocaine and fentanyl. Mainly our opioid supply has been either illicitly manufactured fentanyl or prescription opioids. We don't have a large heroin supply.
And Matt and I are going to be talking about our working relationship and our personal relationship and some activism we've done together and how that's led to our research. And we first met back in, I think it was 2017, 2018 now. Matt was starting to work with a local harm reduction organization called Mainline Needle Exchange, and our first local drug user group called the Halifax Area Network of Drug Using People. And I was working with Mainline to write some op-eds, and I was doing some clinical shadowing as part of my residency. And we met at this documentary screening, a documentary about Mainline's work. And there was a lot of conversations there that day about the need for an overdose prevention site in our city, a supervised consumption site. And we got involved in some early conversations with people there about forming a group to kind of push this forward. And Matt continued to speak publicly. This was at an academic conference. with the Halifax Area Network of Drug Using People. I was in the audience there. We continued to connect and we started texting. And I think that's really when our friendship and our regular communication started. And at this conference, Matt shared a poem that he wrote about the need for an overdose prevention site, which he was also able to share with our government of our provincial legislature.
And at that time, you know, I thought we were getting invited to the provincial government kind of legislature or assembly to advocate for an overdose prevention site. But actually, they just wanted to acknowledge us, and it was like a minute and we were out. But I wrote that poem and advocated with it on multiple occasions. But we had a group of community-based activists and organizations that really wanted to implement an overdose prevention site, but really couldn't do so under their name. So we created an overdose prevention society with the sole purpose of implementing and advocating for Atlantic Canada's first overdose prevention site. And Tommy and myself have used media as a real driving tool for our advocacy, really getting in touch and building a relationship with, you know, key journalists that want to objectively advocate for, you know, kind of what we are standing for, but do it in a respectful way. And we've had many different, like, we probably were featured in the news once a week for a couple months prior to opening the site. We knew that the Nova Scotia government wasn't on board at the time for funding the site. So we had to get really innovative of different ways that we were going to use to hold these weekly meetings and advocate and brainstorm and eventually fund the first year of the site. So we had a GoFundMe that raised a couple $1,000s. We had t-shirts that Tommy and I both have on now that we sold probably a couple hundred t-shirts, probably 500 or 600 t-shirts. We actually did a buy one, donate one, so we could give back shirts into the community to people who use drugs. And for a while, you could go down Halifax and literally see someone wearing these shirts. But it created a way for us to accept money. People would come and just give us a couple $100s for a shirt and say, look, this is like a cause that I'm passionate about, and I just want to give you guys money. And it just created an avenue for us to accept money and put it towards the first year of opening the overdose prevention site.
And this is Matt leading a protest march downtown in our city, trying to convince the provincial government to get on board and support to open an overdose prevention site requires an exemption granted from Canada's federal government, an exemption to our criminal code, and the provincial government wouldn't support us. So we ended up having to go around them and apply directly to the federal government without the provincial government's support. And in fact, they were threatening to withdraw existing funding from the community-based organizations and harm reduction organizations we were working with, which was in part why we had to create this separate Halifax society. And we were successful in the end, bare bones. Obviously, we didn't have very much money. Neither of us had very much research experience at that time. So we weren't even really able to set up an evaluation. But here's Matt behind the front desk at the site with a cup of coffee and the exemption over his shoulder. And this is the letter from the Director General of the Controlled Substances Directorate of Health Canada addressed to Mr. Matthew Bonn, President of Halifax Overdose Prevention Society, granting the exemption so we could open. So that was a big day. This is what the inside. Oh, sorry, buddy.
I was just going to go back to this one. Yeah, because at the time we thought I couldn't get the exemption in my name. I had a criminal record. So we actually tried to put it in Tommy's name. And they reached out to us with questions. Okay, well, is Dr. Brothers going to be there every day? And I said, well, no, he's kind of on the executive and, you know, he may stop in once in a while. And they said, well, who's going to be there every day? And I said, well, I'll be there working for 6 days a week. And so they actually put it in my name. And there is some barriers around supervised consumption sites compared to what we had was an overdose prevention site, more of an urgent public health needs site around people with criminal records. But this route allows for people with criminal records to be leading these things, which is important for something like an overdose prevention site.
And this is what the inside of our first site looked like with 3 booths. There's Matt in there smiling. And this was like, this is the very simple version of the story. Obviously, these things are still controversial, and it was a complicated and painful journey for us in a lot of ways. The site ended up having to close down here and move a couple blocks away. And it was taken up by the leadership of one of those community organizations that initially wasn't allowed to be involved in it. So that was one step forward. And then finally, because there was such a positive experience once it was up and running, the provincial government's now funding 2 sites that are open, which is great. But yeah, again, we didn't have capacity, didn't have the knowledge to do an evaluation, and we really don't have much. We've tried to collect some data from the site, but nothing reliable or robust. And it wasn't yet our research project, but we did start to do some writing together. This was our first published paper. It was a commentary in the Canadian Medical Association Journal on a really great study that Adeline Arteni wrote, who I think might be here tonight, about how patients' perceptions of their opiate agonist treatment dose, if they think they're at the right dose, they have better health outcomes. And if they think they're at the wrong dose, they have worse health outcomes, including a higher risk of hepatitis C incidence, whether or not they're above, the high dose, low dose threshold, 80 milligrams of methadone or whatever. So I was a peer reviewer on the study, and told the journal how I thought it was like badass and awesome. And so they invited me to write a commentary. And I'm a prescriber of OAT, but thought, since it was really focused on the patient's perspective, that Matt could have some really valuable insights. And so we discussed and met and went back and forth and tried to fit all our ideas into one little commentary. And we've published a few other commentaries together about general stuff. We'll talk about safe supply next, but Brendan invited us to participate in a commentary on IJDP, advocating for person-centered language for people in prison and people who are formerly in prison. And then most recently, we wrote led by Natasha Tusnard, also at the Canadian Association of People Who Use Drugs, a commentary on how there's shared social determinants for overdose deaths and HIV infections among people who use drugs. And now Matt's on the team working with me and my PhD, which is awesome. He's really intimately involved in the systematic review that I'm doing, looking at social determinants of injecting related infections, the qualitative manuscript we're about to submit. And Matt was involved in the search term development and screening all the articles with me and doing the initial coding of the papers. And so we were able to compare our perspectives on them. And fortunately, I was able to get a grant from the medical school here to fund his work on my PhD, which enables a lot of this, because obviously he's quite a busy guy.
And around that same time, the Canadian Society of Addiction Medicine was holding their annual conference in Halifax, Nova Scotia. And we really don't get a lot of these large national conferences. So it was great to have CSAM come and do that locally. But as a community member and not being connected with any scholarships or anything, a lot of times we really don't have funding to go. So Tommy was able to not only secure us funds to go to the conference, but also get us in to speak on safe supply. Myself and my boss, Natasha Tusnard, we spoke about the Canadian Association of People Who Use Drugs Safe Supply concept document. At the time, there was little research around safe supply. There was some coming out, but we have a gray lit document that has been cited in a lot of academic literature and has kind of like paved the way for safe supply in Canada. And we got to present with Dr. Andrea Serrater, who at that time was prescribing medical safe supply through hydromorphone and Dilaudid for close to like 3 or 4 years under the radar and having real positive outcomes. So it was great to have both the medical perspective and people who use drugs speak at the conference.
And just in terms of like strategizing around advocacy, the main way I was able to set up this panel was I volunteered as the early career representative on the conference planning committee. And then from really early on, I said, can we have an early career, not necessarily an early career focus panel, but a panel that can I claim a panel basically to set it up. And this is what it turned into. And, it's a relatively conservative audience, a lot of kind of old school methadone doctors. This group, the Canadian Society of Addiction Medicine, has been publicly opposed to safe supply, especially initially, but because Matt and Natasha were there speaking from lived experience from a first voice perspective, it completely set the tone for the discussion. And I think a lot of minds and hearts were open that day for the first time about this need. And so it ended up being a really well-received panel.
And kind of drawing from the momentum and the energy that was around safe supply, and especially at the time, Dr. Mark Tyndall in Vancouver was advocating to prescribe Dilaudid through a vending machine. And this is an automatic biometric secure machine. And it just happened to be that the company that created the machine was in Dartmouth, Nova Scotia, where the office for the Canadian Association of People Who Use Drugs are. So naturally, we reached out to them. We wanted to collaborate and potentially get one of these machines there. It would have provided us an avenue and a way to kind of have a machine, but also start prescribing safe supply. Eventually, it kind of fell through because just the politics around having like a for-profit company and a not-for-profit company collaborating didn't work out. But it eventually led to people being comfortable with the concept and the idea of prescribing safe supply.
And Matt and Natasha did a great job organizing a group of local doctors, including me, and our street outreach nursing team that also does primary care, to be ready to go. Like, even though this vending machine fell through, we had a plan in place to have a safe supply program administered by CAPUD. So people, when COVID came and there was new needs and the urgency started to change, we already had a group of doctors who were like committed to the idea of safe supply.
And right around then too, COVID just happened. There was kind of some like momentum and some publications coming out around safe supply, but not really widely or nationally. And I was doing a lot of journalism at the time for major kind of drug policy outlets like Filter and Katie or Talking Drugs. And I just thought about like, okay, well, if I can get published in some of these like media publications, I wonder if I can get a letter to an editor accepted at some kind of academic journal. So I reached out to my friend Adam Paliu, and I thought like I pitched the idea to him too, and he said, I think you can for sure. And I wrote a letter to an editor for the need of safe supply. And actually the first draft I wrote, I was on mushrooms, and I kind of wrote like a 400-word piece and circulated it to the authors here. And we submitted it to the Lancet, we submitted it to IJDP, and they both got denied, and they were kind of like doing similar stuff around this. So right around then, I had a piece on decriminalization during COVID-19 that the Journal of Studies of Alcohol and Drugs retweeted, and they like DM'd me and was like, anytime you have like a piece that you want to do, reach out to us. So I reached out to the editorial manager and I said, I have this letter to an editor around safe supply. Would you guys accept it? And they're like, well, we don't really accept letter to editors, but if you want to expand it into like a 2,000-word commentary and talk about the piece that you wrote for the conversation on decriminalization, then we'd be happy to look at it. And at that time, we got it published in the Journal of Studies of Alcohol and Drugs, which is the oldest journal related to alcohol and drugs. It was open access. And we got like a couple boxes of hard copies that I gave to all the authors and sent to some of my academic colleagues around the world. And we just happened to get Mark Tyndall. We were working with him on the MySafe thing. So we were in a lot of conversations with him, and he's the senior author on it.
And I think this was Matt's first author publication. And, it's obviously not common to have a commentary published in a journal with three simultaneously published invited responses from some really high profile people like Anna Lemke at Stanford and Brandon Del Pozo at Brown. They published responses from them simultaneously, and it's gotten like 70 something citations already. So Matt's just kicking ass already in the academic world. And it led to a grant that Matt was PI on to do a scoping review and knowledge mobilization around what would safe supply look like during COVID.
And, I think we brought together a very unique and novel team for this grant as well. And something that was really missing from the safe supply conversations were like legal representatives. So we actually have the director of the Dalhousie Health Law Institute as the principal, nominated principal investigator that held the grant, and myself, Dr. Leah Genge, and then another lawyer, Sheila Wildman. all as principal applicants, but we have people like Dan Werb on it, and it's published on CIHR's website.
And I got to be a part of that project too, under Matt's leadership and co-leadership. And some of these times, I was busy at the hospital. Everyone was freaking out about COVID and all this stuff. So I was unavailable, or I was inconsistent or unreliable. And Matt would just kind of keep including me and keep providing me opportunities to stay involved. And I appreciate that so much. We're going to briefly review our recent publication in Drug and Alcohol Dependence about our evaluation of providing safe supply and managed alcohol in the COVID isolation shelters. The study itself is pretty, straightforward and simple. It was just like a retrospective chart review over a month of our experience there. But as Matt mentioned before, we already had some organizing going on about delivering safe supply in general, like outside the context of COVID. And when COVID hit, Nova Scotia had relatively little COVID, and we shut down our borders. We had severe public health penalties if you left isolation and quarantine. People who were unhoused were provided with hotel rooms and then forced to stay there for 2 weeks of isolation, even if they hadn't tested positive yet, just for deemed high-risk exposure. So when there was an outbreak in the congregate shelter system, everybody had to move into a hotel basically in a weekend. So we were following guidance that was informed by CAPUD's concept document, and very quickly spun into emergency guidance out of British Columbia, Canada, to prescribe safe supply to facilitate physical distancing and isolation. And so that was really helpful to have as like a guide, but also to legitimize the practice. Everybody was offered OAT, although very few people who weren't already on OAT took us up on that. People could have hydromorphone tablets, and like Matt mentioned here, a lot of folks are using prescription pills. So people had a really good sense of what they needed, and we were able to match it pretty much perfectly. And relatively fewer people on fentanyl, or tolerant to fentanyl or dependent on fentanyl. And then for stimulants here, primarily that's cocaine. We provided methylphenidate or Ritalin, and dextroamphetamine or Dexedrine, and strong beer, 6% beer, tobacco, and a few people needed benzos as well. There's more details about like dosing ranges and stuff in the manuscript, but just to give you a quick overview, a plurality of people were on alcohol alone. That's that light green. Sorry about that, light green bar in the middle. And then otherwise, people tended to require multiple substances. It was very rare for people to be only on stimulants like Ritalin or Dexedrine, or only on opioids. Most people were multiple categories at once. The experience overall was very positive. People were supported in the hotels from the shelter staff as well, which helped facilitate so much of this. And again, with our street nursing outreach organization, but over more than 1,000 person days in isolation, we didn't have a single overdose. We had 8% of residents left isolation prematurely, but 4 of them returned, and those rates are much lower than what's been published in other descriptive studies. And from our perspective, very rarely were there concerns about over intoxication and medication diversion or sharing. So overall, quite a positive experience. And we just wrote up the study with the retrospective chart review of the dosing and clinical outcomes, uncontrolled.
And, right around then too, we, like we do with a lot of the research we publish, we translate it into kind of plain language summaries and publish it on usually Filter, sometimes Katie, sometimes other drug policy or media outlets. Filter has like an average of 175,000 readers per week, but it allows us to get what we're researching out to a more wider audience. So a couple pieces ago, I wrote a piece on the safe supply of the Halifax safe supply hotels. I got to interview Tommy and quote him. And actually at the time I was looking for like a little thumbnail photo of the Lord Nelson, and I reached out to Tommy and he took a picture. So now he's not just a researcher and a doctor, but he's a published photographer. And it just allows us, it gives us a platform to really get what the research we're doing to everybody that reads kind of these things. And this is a photo actually from the first INSU that I attended back in 2019 in Montreal. I had 2 posters that were accepted. Actually, this one that you can see in the picture is on a program that I was the lead of called the Peers Assisting and Lending Support. It was actually a provincial prison outreach program that was aimed to reduce HIV or hepatitis C or other drug-related harms. But, you know, it just kind of like shows like, you know, you can acknowledge me as a peer or someone who uses drugs, or you can include me into like the projects and whatnot. And I think it's really important, especially like highlighting Tommy and ours relationship, that we bring people who use drugs or people from the community into our circles and, you know, get their perspective on things.
And Matt's now, you know, as we've reviewed just like a snippet of it here, but leading research, PI on grants, leading international teams, writing papers. So he's kicking ass. So just to summarize and wrap up here, you know, Matt and I have different backgrounds and different life experiences, and we bring different perspectives to the table, but we share a lot of values and we enjoy spending time together. We really enjoy working on these projects together and brainstorming and looking for opportunities and making things happen. So even though the advocacy work, you know, largely around the overdose prevention site first brought us together, and then advocacy around safe supply first continued to bring us together, that really developed our friendship, and everything else has built from there. So now we're kind of like, you know, if I have an idea and I'm just text Matt or give him a call and run it by him, see what he thinks. If he has an idea or an opportunity, he's texted me. And we're working together on stuff because we enjoy spending time together and working together.
You know, and having both of our perspectives, having, you know, especially working in the field of drug policy and harm reduction, you know, and engaging and collaborating with new researchers, you know, having like someone with lived or living expertise come and share their perspectives and being backed up by somebody, you know, a medical with medical training and a medical resident that it's also doing research. It just really helps kind of like concrete your perspectives and like validate what you're saying. So really, you know, like there's not too many projects that I'm involved in that Tommy's not involved in, because we really do think of each other when we're working on new stuff. And a lot of research opportunities have come from our relationship.
And this is the last slide of our presentation. It's Matt and me hanging out with our baby. My not my baby with Matt, but my baby Simon with my wife Lindsay, and Matt holding him and feeding him when he was really little, and us on a walk a little while later. And there's our contact info. We're obviously happy to share it elsewhere as well.
Tommy, it really looks like it's our baby with the middle photo.
We're so proud. We're so proud of him.
Little Simon.
Yeah.
That was funny.
Awesome. Such a great presentation, guys. Like, just so much respect for everything you guys do together. Yeah, thanks so much. So now we might just have a bit of a chat. I've got a few kind of questions related to what you've presented and some other things that are thought of in general. But yeah, obviously, as I said, if anyone else has any questions, we'll have a bit more of a Q&A shortly. So I might start with you, Tommy, if that's okay. Just wanted to get your perspectives. You know, you're a medical doctor, you're doing a PhD, so, you know, very much an early career researcher by doing a PhD. Just wondering if you can talk more about how you think working with Matt has impacted the work you do, both as a doctor and researcher. And, you know, I know it's hard to frame it, but if you didn't have the relationship with Matt, how your work might be different.
Yeah, that's a great question. I think the medical perspective, and maybe like the biomedical perspective more generally on substance use and addiction, is so limited and limiting. And, you know, full of all these contradictions. Like, we assume people have no control over their substance use and no power in their lives, while we fail to provide them with adequate support and services and punish them and criminalize them. Like, you know, all those things. I'm sure this crowd's familiar with all those contradictions, but like a lot of my interest in this and some of how I got interested in doing advocacy around it was seeing the failures in our health system firsthand. Like I'm a medical student and our patient with a life-threatening infection in the hospitals forced into withdrawal. We're not giving them any pain medication. And I'm like, this is fucked. Like, what are we supposed to do? And no, doctors were like, we can't give them drugs. They have addiction to drugs and all this madness. So I started hanging out with the harm reduction organizations to try to understand the different perspective and got to see it firsthand, you know, like unconditional love and support and people who use drugs at the forefront and sharing their experiences. And so that was kind of what I had in mind and the questions I was asking when Matt and I first got connected. And then it's been like, our relationship has been hugely educational for me as I've undergone my medical training and the pressures of our healthcare system and getting trained in the medical model and pathologizing things and trying to treat them and fix them and trying to make people change their behaviors and do what we want them to do because that's what we think is healthier for them. And I just share all these stories with Matt and we talk about all sorts of things. And it's been an incredibly educational experience for me to work with Matt and CAPUD and Natasha and the local organizations and get to learn a different way about considering substance use and people who use drugs as people and respecting their human rights and figuring out how we can support them rather than punish them.
Yeah, great. Thanks so much, Tommy. Now, Matt, as someone who is very open about your drug use, you know, and for that matter, your criminal record, but is now, as you've mentioned, Tommy has reiterated a lot, you're now very much doing research, leading research. Just wondering if you could further expand on what you think the challenges are for people who use drugs and for that matter, people who have criminal records to get more involved in research and lead research.
You know, I think it really comes down to actually like leading research and applying for grants or holding funding. You know, a lot of times, you know, people who use drugs have these great ideas and, you know, they can collaborate and empower people, academics to kind of like look into this aspect of drug use or that aspect of drug use, but they can't really lead the research if they're not, you know, a PhD student or not a PhD, don't have a doctorate. So I think, you know, a lot of the challenges come down to structural reasons. You can do some community-based research, but I think, you know, finding those relationships, I've been very lucky and, you know, very grateful to like, just be open about who I am and what I do. And, you know, like a lot of people in the field respect that and I get a lot of opportunities, but I think, you know, kind of like the stigma and discrimination against drug use, the criminalization, all those things kind of trickle down into this, these little things that hold up a lot of the research. But, you know, I've been very lucky to have people help me like, more or less, like I feel like I've gone to school to do a lot of this stuff because I have people that are in school learning it, translating what they've learned to me. And, you know, like if it wasn't for them, I don't know if I would be where I'm at today. So, you know, I think really if we can start to like allow people to be these things, allow community-based organizations to hold research grants in collaboration with researchers, we'll start to see more people get involved, because I think as people who use drugs, we're naturally curious and, you know, we really are, you know, born researchers. That's what, you know, when a lot of people, when they use drugs, they say they're, you know, they're researching on themselves, right? So like a lot of people that are using, that's what they're doing. They're going and trying different types of chemistry or different chemical formulations on their own body. They're kind of researching themselves.
Yeah, great. Thanks, Matt. Maybe just one, just conscious of the time. You obviously have done some commentaries together, and that's how I first, you know, worked with you, met you two. Just wondering if you could further reflect on, you know, the role of commentaries as kind of like a tool for advocacy. And there was a point in, I think, your final slide about social media, you know, and how that kind of impacts on the work you're doing, as you said, Matt, getting the message out there more broadly beyond the academic journals. Just any kind of further thoughts on how we can do that better as well?
I think we can always, if you're writing a commentary, if you're working with any community-based organization, there's going to be somebody that can, read that and provide an input. So if we can include them, include their expertise, try to use media as we can to translate it to the plain language or, kind of lay summaries. Because I always say people who use drugs do a great job at like translating academic literature into kind of plain language and vice versa. So anytime we're writing commentaries, we should be writing like other pieces to complement them, to be more accessible to maybe somebody that's not as familiar with that kind of lingo or that kind of that type of writing. And I think, really social media is a great tool to, dispense it or disseminate all that research. But it's really comes down to relationships, so you have a relationship with journalists, you can like push a story on them if you're writing something cool. And that's going to get a lot more eyes than you could by yourself. So I think, just expanding and building those relationships and nurturing them over time.
And Matt's obviously a man with many talents. And so he's taught me a lot about communication. In Canada, we use the term knowledge translation. I'm not sure if that's something everybody's familiar with, but like, how do you communicate the evidence into different spheres like the public and policymakers and get it in front of people? And some of that I think came from Matt's passion of writing and wanting to do journalism and then doing journalism on his own science. But part of that I think came, I remember conversations relatively early on about how like science that just stays in journals or stays in a box, like either doesn't reflect real life as much or is a waste of money and time. So Matt's always been pretty passionate about wanting to get the stories out and get the conversation out. We've been involved. I don't know if we've published any op-eds together. We've each written op-eds with different colleagues on local and national issues, kind of in online magazines and newspapers. We've written a couple commentaries we shared about about like writing to clarify our own thinking, like around the social determinants of health piece. Some on controversial issues like the early stuff on safe supply and getting the logic of it and the rationale for it out into the medical journal, so that then that can be cited and people can say, okay, this isn't like a zany thing, and start to legitimize it. And then some of it around, wanting to actually affect just the scientific discourse, like the commentary Brendan led around person first language. But and to Matt's piece about getting friendly with reporters and journalists, that's been hugely helpful. We have a couple of allies locally who we can say, this is happening. It started with like the protests around the OPS, but now it's when our papers are coming out and we know that they're kind and thoughtful people and they're not going to try to spin it into some drug war scare story. They're going to actually engage with it and tell like a fair story in their reporting, which has been incredibly helpful resource as well.
Yeah, awesome. Yeah, really good. Good points to consider. Yeah, definitely we need to get our work out there into the broader world for sure. I might now hand over to Anna Conway, who will lead the Q&A. So like I said, pop your questions into the chat, or if you want to ask your question live, as live as Zoom can be, pop your hand up. Thanks, Anna.
That was a great presentation. It's really fascinating to hear about your work, guys. Thank you so much. Maybe I'll just follow on from what you were saying before. I'd be interested to know if there was maybe for particularly people that participate in the studies or you've collaborated with, have you found there's any good ways of, or any ways that you found to communicate results or communicate the findings of studies or even commentaries more locally? So maybe people who, don't keep up with filter, or they don't maybe aren't the target audience of maybe published pieces.
Go ahead, Tommy.
We've had a couple strategies around that. Both of us are pretty active on Twitter, especially, and we engage with like local journalists on Twitter. So when we post about something like a new paper coming out and we do a thread and it gets retweeted and picked up, a bunch of them end up like direct messaging us to say, are you free for a Zoom video interview tomorrow or this afternoon, or can I call you about a news story, because journalists are always looking for pieces to write. As we've done more research, and we're not as much, because previously we were really proactive about this from the advocacy point of view, like trying to get the overdose prevention site story out there. But now that it's more focused on research, we've also had a lot of success through working with university press offices and press releases. And I've spoken with another, like, I'm still relatively early in this research thing, but Matt's taught me to really like get the message out there. So I'm contacting the press offices like with every paper that gets accepted, no matter how small it seems, and saying, would this be interesting for a press release? Do you think there'd be pickup on this? And a few of them have done like media blasts about papers that are otherwise, not super groundbreaking or anything, but just because I got in contact with the press office, they were like, oh, cool, this is interesting. Like, let's tell a story. And I don't think I'd be doing that if it wasn't for Matt either. So thanks, buddy.
Yeah, and I think, Tommy, like, I know the Safe Supply Hotel piece got acknowledged in the press. The JSAD Syndemic Safe Supply and DCRAM got acknowledged in the press. And I think, like at first we were kind of like Tommy said, we were advocating, but, they always want to have an objective view. They want to have different perspectives. So we could just come as like a package deal and say, okay, well, I'm a doctor and I'm a drug user. Here's your story. And they don't have to like seek out an additional perspective. But I think, a lot of times we've presented together on online conferences or panels. And I know even like some of the research that, we get invited to review a lot of the same publications and stuff. So people have acknowledged that we have this unique dual perspective that, okay, I can bring this in and get like a comprehensive outlook on this manuscript, or invite us to be an author or whatnot.
Yeah, that's great points, and especially what you were saying about sharing with the university, like I suppose places that it would be published and be shared with the different audiences that I hadn't thought of before. And within the university, because especially now you're in the PhD, and Matt, you're a PI on different studies, is there anything that you found particularly within the structures of the universities that can be like blocking to collaborations? I know, Matt, you mentioned before about there's often like blocks on CB or community-based organizations trying to hold grants. So is there any other examples like that you think are blocks within academia for partnerships like yours?
I'll just mention quickly, and I guess it's a little bit to like follow up on the funding piece, but a lot of times through these academic institutions, paying people to be involved in your research or whatnot has been very hard or difficult, right? A lot of times you may want to pay people or e-transfer them or whatnot, but the university makes you go through these back channels, and it takes a month or 2 months to get paid. And for someone who uses drugs, and you're acknowledging and respecting their time that they're using right then, and you want to pay them quickly, it just becomes a barrier to include people right now and then.
And some strategies we've used on grant applications, and a couple of grants, have been to partner with organizations in a way that the academic partner can hold the money in an academic account, but that the community PIs, the people with lived experience, the peer researchers, can access their money through salary buyouts or like chunks of money transferred to the organization. So for example, Matt and I just submitted a grant to do a Delphi thing on endocarditis and injection drug use, and two drug user groups are partnered on that. And the way we wrote the budget, we would just transfer a chunk of money to do salary buyouts for the organizations. So they don't have to like become research assistants or like employees of the university, of the hospital, or anything like that. But it's also not individual e-transfers either. And partnering with the organizations is also, I think, like a nice, helpful way to build capacity and sustainability and all those good things.
And just
that's really good.
Follow up on that, like it really helps, like at the end of the grant, if you have like $10,000 left over and you don't know what you're going to do with it, you can just immediately transfer it over to the community-based organization. Like we just got a chunk of change because we still want to publish our narrative review on safe supply and have like open access fees. So it's got transferred over to us, but it just allows money to like go, we don't have to transfer it back to the academic institution. We can still use it down the road. It doesn't have to, we can think it out and see how we want to use it, and it doesn't expire.
And another quick thought on that is that a lot of universities have started to build offices or infrastructure to support either co-production, like community engagement or patient engagement in research, or patient-centered research. We have a couple, we have like a separate kind of network that has grant support, and they'll like review your grant and connect you with resources and stuff for patient-centered research. So I've contacted them to say, does partnering with people who use drugs on research count as co-production and patient-centered research? And they're like, of course it does. And then get them on my side to help navigate any other barriers or connect with other resources. And it does align with their values, and we've gotten some help that way too.
Yeah, I love that. It really like cuts across what is often like difficult to negotiate or like very opaque university structures. Try and get someone on the inside of administration or with interest in community collaboration to get on your side. Maybe kind of related to that, I was wondering about in terms of if obviously you've co-published a lot together, but do you work with more formalized kind of community panels, or do you tend to, just because the work is collaborative, you don't have kind of groups of people in case you need to consult on issues that are maybe outside of your areas of expertise, your many areas of expertise?
I think, it kind of goes to the question in the chat around advisory committees and whatnot. And I know like some people who use drugs may not prefer that term because they feel like they're advising, but at the end of the day, the group does what they want. So they rather like steering committees or things that they actually have some kind of influence. And I think, really, if you want to get the most out of them, you got to find a champion. There's always kind of one or two people that are really involved in the project or really interested in the project and want to be involved more. And that's, I think, when you start to build those relationships that you want to like, okay, I want maybe, that person, I really like what that person said, and I really like their passion and energy on this project. I'm going to reach out to them and invite them to be a little bit more involved. And just kind of like, you don't have to give people these large roles, like, inviting someone to review a manuscript, but I like making sure that, they can hear their voice. They can like really like provide a meaningful input onto something. It makes a huge difference for kind of the sustainability of these relationships.
And I think I've met some early career people and PhD students who have done an amazing job of this with, a community panel or a community board and engaged in their whole like, multi-year mixed methods grant funded fellowship project. I like, we've been talking about a number of different projects with a number of different like structures that are sometimes partnerships with community organizations. I haven't worked with anything like a community advisory board on my projects, partly because some of them have been like relatively small, or we've been doing them on the side of our desk without any funding, or getting into my PhD now, like I had to change my whole plan because of COVID and I couldn't move to England and all this stuff. But Matt and I have talked about like in a couple of years, I'm hoping to get a faculty position to start a research program at the medical school here. We're going to look to models elsewhere for ways to, provide funding and employ community members to be engaged throughout, and try to set up a research program that way with community involvement. And I know there's some good examples, like here in Canada, the MAP Center for Urban Health Solutions in Toronto has a urban scholar or a community scholar position, and a number of their projects have community partner boards and stuff. So I haven't quite figured that one out yet, but I think our relationships have kind of gone project by project and trying to figure out an impactful team and pay people for their expertise from the grants that are available for these smaller projects and that kind of thing.
Yeah. And we just got invited to both be collaborators on a social science and humanity research council grant application. And like typically they were looking for a PI in Halifax, and we just didn't like any of the PIs that we were thinking of just didn't really have capacity, but we managed to say, well, you know, Tommy can potentially lead and hold funds in a couple of years, and I can provide a community-based aspect. So we're both collaborators. So we kind of like are trying to find ways around some of those barriers, and just allowed us to still apply for the grant and potentially do the research locally.
And in as like one kind of general message, I imagine the audience here is kind of already engaging with these issues and already interested in this, but something that comes up a lot locally when I'm talking to students or people who are interested in this, like especially coming from a medical school background, we're kind of trained to be enthusiastic and solve problems and come in with solutions to propose and that kind of thing. But a lot of our projects have come out of, you know, what's in the interest of the community, what's in the interest of the harm reduction programs, what's in the interest of the drug user groups. So for people who are students and are looking for opportunities to get involved and make a difference and start to build some of these relationships, just going and to some of these organizations and explaining, you know, you have these strengths and you'd love to help them with anything, you know, whether that's flexible time, writing skills, grant writing skills, that kind of thing. That's how you could start to build relationships without having to come in with already all the answers to everybody's problem and a fully formed research project, but start those conversations, build those relationships, and learn and listen and try to understand what the problems are that a researcher might be able to contribute to and evaluate and publish and legitimize and back them up and all that stuff.
Right. So we've covered Bridget's question. Thanks for that. And maybe we just have time for one more. I was wondering, especially thinking about what you were saying in the future, you hope to get a faculty position and then be in a position to, well, maybe have like salaried employees. And I was wondering if like what kind of aspects, or if you have any thoughts on what makes a good working environment, bringing that forward.
Yeah, that's something I don't necessarily have a simple answer to yet. I think some of the issues we've kind of tangentially touched on earlier are still going to be problems at an institutional level, like, you know, criminal record checks to try to employ people in a research institution environment, you know, a research institution environment that might not be the most welcoming or supportive for people from non-academic backgrounds and that kind of thing. So I think, like, you know, ongoing partnerships with these community organizations, having flexible ways of paying people, having flexible ways of scheduling people, like, you know, patience. And like, I like to share that I was sharing earlier, for example, and I think tonight that, like, I would go radio silence for a couple of weeks because I'm on a really intense clinical rotation. And so I appreciate when people can be flexible with me, and I hope to do the same if people are busy at different times or have different needs at different times. But Matt might have a better answer for me than this one about how to create a working environment together over the long term.
You know, I think it's really like, you just have to create a safe and open environment as you would like for yourself. And I think, you know, like, students use drugs. So if you are working with a student and you can pair them up with somebody in the community, that's great. Like, why not have multiple research assistants on your project? Like, I've been employed by Dal for various different research assistant jobs or at St. Mary's. And I haven't really faced that barriers, but you know, I'm very lucky to have like the PI more or less vouch for me and say, you know, I'm bringing this community member in to be a research assistant, give me access to, you know, libraries and online databases, like things that typically are barriers for me to engage in research, suddenly become a lot more available if you have somebody like Tommy, or, you know, somebody doing research that is going to say, can I like include you? And, you know, I think, you know, just like allowing people to come how they are and who they are, like that's what you want their expertise for, that's what you want their experience for. So if they come and they're high or they whatever, like, you got to acknowledge that that's what you need from them, and maybe that's the perspective they need to show you that day. So just being flexible with people, as Tommy said, regardless if it's time, if it's capacity, if it's, you know, how people are. Like, Tommy has been very flexible with me, and, you know, like, I'm grateful for that.
Thank you so much, Matt. Thanks, Tommy. I'm going to pass quickly back to Brandon to wrap up.
Great, yeah, thanks for leading that Q&A, Anna, and thanks again, Matt and Tommy. So we're almost at closing time, so I'd once again like to thank everyone who joined our first INHSU EMCR Special Interest Group webinar. It's hopefully the first of many to come over years to come. So, I mean, most people in this audience already well and truly are aware of INHSU and everything we're about. But yeah, as I said, we do have now an official INHSU Special Interest Group. So if you'd like to sign up to, if you haven't already, to be more involved with that, that would be amazing. Yeah, so with that, thanks again, everyone, and hopefully look forward to seeing many of you in Scotland in a few weeks. Cheers.
Thanks, everyone.
Thanks, everyone.